Improving Patient Outcomes Through Nursing Leadership at the Bedside by Kelly McEvoy. Working as a registered nurse in the post-anesthesia care unit, severe postoperative pain in the orthopedic population is commonly seen and especially difficult to manage. Meisner et al. 2015 explains that poor management of postoperative acute pain can contribute to serious medical conditions including pneumonia, deep vein thrombosis, infection, delayed healing, contractures, and the development of chronic pain. Therefore, it's imperative that patients undergoing surgery receive adequate pain control. Unfortunately, evidence by Meisner et al. 2015 suggests that this is not currently the case in regards to the orthopedic surgery population. The purpose of this project is to reduce postoperative pain in the orthopedic surgery population with the use of preemptive analgesia that aims to improve the nursing staff's knowledge regarding the need for and administration of evidence-based preemptive treatment modalities that are effective in reducing postoperative pain in the orthopedic population. The nurse's knowledge is evidenced by a minimum successive 10% increase in post-test scores following each of the 4 education sessions, or upon achieving the final goal of a post-test score of 90% or higher. This promotes leadership at the bedside because I identified that the post-surgical orthopedic population's pain levels were not adequately controlled. Therefore, I developed a quality improvement plan with my team members. This provided a foundation to collaborate with leaders from other health professions. I provided education sessions that motivated my colleagues to follow my lead, which Duffy and Smith 2013 describe as a pivotal skill of nursing leaders at the bedside. This project also promotes nursing leadership among the bedside staff nurses because it enabled their autonomy in directly influencing patients' pain management and outcomes. Meisner et al. 2015 speculate that lack of success in providing relief from pain in the postoperative period attributes to health professionals' insufficient knowledge regarding this topic. They suggest educating professionals about the repercussions and magnitude of postoperative pain to increase their awareness of the importance of adequate analgesia. In order to do this in the facility in which I work, I formulated a team and educated them on the project and goals. The team members included were a preoperative care nurse who performed education to her unit and was available for questions, a nurse anesthetist, a PACU nurse who helped perform chart audits and run statistical analysis, my nurse manager who approved all aspects of the change and helped present it to the IRB, an orthopedic surgeon who approved the change for his patient population, an orthopedic physician assistant who relayed information to the attending and was pivotal in developing the physician order sheet, and our nurse educator who helped design and organize education sessions. Although not team members, I also collaborated with the nurse manager from the orthopedic surgical unit who helped spread the change, and a nurse practitioner from a neighboring hospital who helped implement the change. In order to improve pain management in the orthopedic surgery population, I needed to evaluate the patient's intensity of pain and their narcotic demand following orthopedic surgery in our facility. After approval from the Director of Surgical Services to do this, I developed an audit tool and partnered with my team member and fellow PACU nurse to perform 250 chart audits. After running a statistical analysis with the software StatCrunch, I found a mean average pain score of 5.376 on a verbalized pain rating of 1 to 10. Using the same software, I found a mean average narcotic demands of morphine 6.33 milligrams, fentanyl 175 micrograms, and dilaudid 5.06 milligrams. These statistics support my theory that patients' postoperative pain management was not adequate in the orthopedic population in the facility in which I work. I discussed my findings in a team meeting and concluded that preemptive analgesia protocol and a physician order sheet should be devised and implemented. I researched numerous articles that supported our change and provided medication guidelines. An article by Parvizi and Bloomfield 2013 suggested a preemptive multimodal medication regime of acetaminophen, Celebrex, and extended-release oxycodone. During my research, I also found numerous articles that supported adjunct medications for preemptive postoperative nausea and vomiting in the orthopedic surgery population. Ibrahim, Khan, Nizam, and Haddad 2013, found that the administration of Zofran and Decadron effectively reduced postoperative nausea and vomiting, which was also added to the physician order sheet and protocol. After devising my protocol, my nurse manager, who is also a team member of mine, helped me present this information to the Institutional Review Board, where it still awaits approval. The delay in IRB approval was a massive barrier to my initial goal of proposed change. I initially intended to run PDSA cycles regarding the effectiveness of our new treatment modalities. I managed this barrier by changing my aim to improve the nursing staff's knowledge regarding the need for an administration of evidence-based preemptive treatment modalities that are effective in reducing postoperative pain in the orthopedic population. This change was actually beneficial because it better prepared the staff for implementation of our new treatment modalities and protocol, which my previous aim minimally addressed. The change concept is to improve patient outcomes by preparing the nursing staff through education sessions regarding the addition of preemptive treatment modalities in our facility. I implemented the change by performing 4 distinct educational sections that built on the nurses' educational needs indicated by their previous test results. I designed 40 test questions, of which 10 were selected to test the nurses' baseline knowledge prior to the first education session. Dickerson and Chappell, 2016, state that the test-retest is a valid tool to evaluate individual nurses' competence. The first educational session was a meeting in which my team member and I educated the preoperative and PACU nurses regarding all steps of the proposed change. Staff nurses were retested using the same pretest immediately following the session. All test scores increased by at least 10%, but I noted comparisons among the questions answered incorrectly. The test results indicated that they did not understand why we chose the specific treatment regimen that we did. The next educational session, I chose an article to submit to our monthly journal club in the preoperative unit in PACU that supported the medication regimen that we chose. I took information from the journal article to design bulletin boards in the PACU and preoperative break rooms. After allowing a week to view the journal article and bulletin boards, I randomly selected 10 questions from the 30 questions that were left that I initially devised and retested the nurses. At this point, some nurses had met the aim of a post-test score of 90% or higher, while all except 5 nurses met the minimum successive 10% increase on post-test scores. At this time, I knew I had to devise a plan to help nurses better understand how preemptive treatment modalities will affect patients' post-operative course. LEOR 2015 suggests the use of a guest speaker because it offers a new perspective and variety in the way information is taught. LEOR also suggests that when a guest speaker is used, it allows for a better one-on-one approach, leading to a better understanding of a topic that may have been unclear. Therefore, I contacted an orthopedic nurse practitioner from a neighboring hospital who successfully uses these treatment modalities at the organization that she works. She agreed to come guest speak, but the earliest date that she could come was 2 weeks from the previous education session. With a delay in educational sessions as a barrier to meeting my timeline, I used this opportunity to begin spreading the change to the post-surgical orthopedic unit. After meeting with the nurse manager of that unit, she took on the role of educating her staff members at their next meeting. I soon realized that the nurse manager from this post-surgical orthopedic unit played an important role as a facilitator in spreading the change. At the meeting, I performed the same test-retest on the surgical orthopedic unit nurses that I initially used in my first educational sessions. Again, the scores improved by a minimum 10% when compared to their baseline score, but there was a lot of room for improvement. After the session, I provided the staff members from the post-surgical orthopedic unit with the same journal article that I gave the preoperative and PACU nurses and designed the bulletin board in their break room in a similar fashion. After allowing a week for the nurses to view the article and bulletin board, I had them take another post-test. Everyone had successfully met the minimum aim of successive 10% increase in post-test scores, but only one nurse had achieved the final goal of achieving a 90% or higher on their post-test. Now that I had begun to successfully spread the change to the post-surgical orthopedic unit, I had them partake in the guest speaker educational session at the same time as the preoperative and PACU nurses. I rotated the nurses through the PACU break room every 15 minutes, and the nurses were given a post-test after the completion of their session. I recorded the guest speaker's first round of education and later played it for the evening shift nurses. As the evening nurses rotated through the break room, they were also given post-tests after completion of their session. The test results drastically improved, with all except 6 nurses from all 3 units achieving the final goal of a post-test score of 90% or higher. Choosing to have a guest speaker interact with the staff nurses during an educational session greatly facilitated the implementation of the change. SOPR 2017 states that students differ in varying ways, including the ways in which they retain information and may respond differently to various types of education. SOPR suggests that self-study take-home packets provide a form of instruction methodology that gives learners an opportunity to work individually according to their own needs. Therefore, I developed a self-learning packet for the 6 nurses who had not achieved the final aim of a post-test score of 90% or higher. After allowing 1 week for studying, I used the final 10 questions left from the original 40 that I devised to test the 6 nurses. All 6 nurses achieved a post-test score of 90% or higher. I applied the PDSA cycle to the educational sessions to achieve the steps of change. The objective of the educational sessions was to improve the nursing staff's knowledge regarding the need for an administration of evidence-based preemptive treatment modalities that are effective in reducing postoperative pain in the orthopedic population. My prediction for each session was that their knowledge would improve the more education that they received. I planned to test the change with the test-retest method. The nurses would be given an initial baseline test and then post-test following each education session. I personally wrote the test questions based on the information I found in evidence-based articles and our plan for implementation of preemptive treatment modalities in our organization. I plan to grade the tests myself and compare the post-test scores to their previous score and analyze for improvement, as well as for areas of weakness. After the planning section, I carried the post-test out following each session, which represents the due section of the PDSA cycle. In the early stages of analyzing the data, I documented that not many nurses achieved the goal of 90% or higher following my second education session, which I thought was an unexpected observation. In between each education session, I compiled and analyzed the results of the post-tests consistent with the study section of PDSA. I compared similarities between test questions that were answered incorrectly in order to target areas that needed further education for future sessions. Also, I spent time preparing a plan for the next education session based on what education tool I felt would improve the nurses' post-test scores representing the ACT section. Now that the staff nurses have met the aim of the project, they are prepared to immediately implement the practice change once we've obtained IRB approval. Summerback, Hagen, Tora, Casa, and Hermstead 2016 suggests that leaders should involve staff early in the improvement process and ensure that they have necessary education and training. By meeting the aim, this indicates that nurses directly involved in the care of orthopedic surgical cases are knowledgeable regarding up-to-date evidence-based treatment modalities for this patient population that we plan to use in our organization to reduce postoperative pain, nausea, and vomiting. Additionally, passing a post-test with a score of 90% or higher supports that the nurses are proficient in pain assessment, medication use, dose, side effects, peak of action, half-life, pain reassessment, magnitude of postoperative pain, the pain scores and narcotic demands of this patient population prior to implementing our change, as well as the potential repercussions of poor postoperative pain control. Once the IRB approves the proposed change, the next step will be to reevaluate patients' postoperative verbal pain scores and narcotic demands for 3 months following implementation. These statistics will then be compared to the initial statistics prior to implementation of preemptive treatment modalities. I anticipate that the patient's postoperative narcotic demands and verbal pain scores will decrease following our proposed change. This will impact patient outcomes by decreasing the risks that I previously discussed that are associated with poor postoperative pain control.